My topic is CID in therapy in adult congenital heart disease. I'm Sang-Weon Park. I'm actually EP guy in Sejong Hospital. CID in adult congenital heart disease is with the growth of ACHD population, arrhythmia have emerged as a major cause of morbidity and hospital admission and mortality. And the CID utilization has increased in adult congenital heart disease for bradycardia, sudden cardiac death prevention, and heart failure management. And ICD and pacemaker procedure increased on 10% and 30% respectively recently. It is the data from the US reimbursement company and projected annual US estimate of the adult congenital heart disease admission increased with ages. And it is a 2020 ESC guideline for adult congenital heart disease. There is a SVT, ventricular arrhythmia, bradycardia preference, and the sinus node dysfunction is usually in the Epstein anomaly, atrial switch operation, outopulmonary connection, intracardiac lateral tunnel, and there is a AV block is more in the ABSD and CCTGA. About 1/3 of CID in adult congenital heart disease is using the epicardial approach, but the epicardial approach showed more CID and lead failure compared to transvenous system. This graph showed the CID failure in the transvenous approach, epicardial approach, and lead dysfunction is more in the epicardial approach. Unplanned intervention is also usually similar, but so I'd like to show my case of the transvenous approach in the difficult case. Yes, it is a difficult venous access, venous obstruction, coronary sinus location, high capture threshold due to fibrosis, valve-related tissue, anatomy of corrective surgery is very important for the CID implantation in congenital heart disease. So first step is knowing the anatomy is the first step, and usually determine the venous access before any incision. I'd like to show my case. It is the dextrocardia with the six-sinus syndrome, but it is very similar to the usual pacemaker from the right side. So it is this case, and in this case, he showed some sinus node dysfunction, and the CC showed some different axis and sinus port. So we did the pacemaker from the left side. This patient is a complete AV block after some cardiac surgery. I think it is ABSD at 1 year old, and she had PRSBC. So but we did implant the pacemaker via the PRSBC. So it is RA lead and this IV lead, and I tried to place the IV lead at the IV septum because the IV septum showed a more narrow paced QRS as compared to apical pacing. It's another case of the PRSBC and the cardiac pacemaker from the via PRSBC. I'd like to show another case of the ICD implantation for the patient with the BCPS. BCPS means to reduce the IV inflow by SVC, cutting the SVC, and it connected to the pulmonary artery, and so it reduced the IV inflow, and so it is usually for the IV dysfunction patient. This is the cause of the ICD. For this patient, we did ICD implantation, who showed the IV dysplasia with the severe IV dysfunction, and he experienced 3 years ago TB repair, BCPS, and AS closure, IV aneurysmography, and this is a result of the ICD implantation via the PLSVC. It is where after guide wire and is stopped here, and we advance the guide wire from the SVC to the pulmonary artery and RV. It is the result. And we can input the ICD lead in the RV via the pulmonary valve. And so it is the result of the ICD after final result of the ICD implantation via the BCPS. And after 3 years later, she did cardiac transplantation. And I like to show some new system, subcutaneous ICD system. It used the defibrillation for the ventricular tachyarrhythmia, and there is no vascular access. So when limited vascular access, we did subcutaneous ICD system, and the low risk of system infection, preserved vascular access, and lead extraction is more easy, and the fluoroscopy is not required. And the generator put in the lateral side and put the lead by subcutaneous approach. It is a small pediatric patient with hypertrophic cardiomyopathy, and she did sudden cardiac death before. So we did dual chamber ICD implantation at that time, and he showed a very sick myocardium and the dual chamber ICD implantation. But 1 month later, she did the left arm swelling, and so we suspected the left subclavian stenosis, and the anticoagulation with warfarin started, and the swelling resolved after 2 to 3 days. So it's okay. But 6 months later, she did pocket infection, pocket erosion. So we should explant this system and the new approach. So SICD was done after extraction of total system, and she now feels some. I usually feel the patient feels more comfortable using the SI system at the generator at the left flank rather than left subclavicular area, using the arm very freely, and they more comfortable than the usual conventional ICD system. This is another case of the familial HCMP and this sudden cardiac death, and he is an elite athlete with a gun shooting. So we did SICD for this patient, usually more free movement of the both arms. It is after implantation, he did another experienced the shock by VF. It is, so he is now. And there is, but SIC system has some disadvantage over it did not pacing. So nowadays, more, I think next year it will be adopted, launched in Korea, and the extravascular ICD by the Medtronic system. It did implant the shock lead on the substernal area, and then it is very usual with the subcutaneous system. So it can pacing the heart by very contact with the pacing lead and myocardium. But we have no experience as yet. And I'd like to some CRT case of the congenital heart disease. It is corrected CCTGA, and she did the pacemaker at that time, but he showed us some ventricular function, ventricular dysfunction at that. So we did CRT system at the contralateral side of the previous pacemaker, and we implanted the pacing shunt lead, RA lead, and the LV lead by coronary sinus. So after before CRT implantation, the pacing ECG is like this, but it showed a more narrower after that CRT upgrade. So patient feels more better and doing well. It is another case of the correct TJ of the AV block and the atrial fibrillation. So he have already the epicardial pacemaker system, but when we decided to the CRT upgrade, but we have planned CRT system via the PLSVC. So this is the result of the CRT via PLSVC, and then RA lead, IV lead, and the LV lead is like here. I showed my procedure. Some angiography showed us some small branch here with PLSVC. So I selected that branch with using the some inner caster, and we can implant the LV lead by this area. We have already implanted IV lead by PLSVC, and then we can cannulate the proper coronary branch, and then the result of the CRT implantation at the PLSVC patient. And it is the ECG of the pacing, biventricular pacing. It is another case of a CRT in PLSVC. He is 26-year-old. He did many surgery. I don't understand what this means, but he has a complete AV block and he already pacemaker. And 10 years ago, he experienced a cardiac arrest. So I did ICD implantation at that time, but he showed more ventricular dysfunction. So we decided to upgrade to the CRT system. It is the 10 years ago, he did implanted ICD system via the PLSVC, because for the ICD, not pacemaker, for the ICD, it is very important to shock between shock coil and the generator. The most of the heart is because here, so when generator is the right side, it does not cover the heart. So at that time, we did implant the ICD at the left side. At that time, we did angiography, venography, and they showed us some branch. So implant, we inject, for guidewire cannot pass, so I decided to explant the arterial lead, because they showed some arterial lead showed lead dysfunction. So after extraction by the sheath, so explanted the arterial lead, and then implant arterial lead again, and show the CS branch, coronary branch, and we can cannulate the coronary sinus branch and implant the LV lead at that site. This is the result of the CRT at left PLSVC. I showed some unrecognized anomaly during procedure. It is the innominate vein obstruction, so we cannot go more by this patient. And during CRT, we did not recognize some anomaly, but we cannot cannulate the coronary sinus at the time, so some contrast in the pericardial space. So we did the coronary angiography to show the left coronary sinus anatomy by level pace. So it means it showed some membranous obstruction at that coronary sinus area and dilated of the coronary sinus and myocardial vein. So after CT image, membranous structure obstructed the coronary sinus source, and the coronary sinus and myocardial vein was dilated. In that case, we call the surgeon for the epicardial LV lead insertion. My conclusion, CIED in adult congenital heart patient increase with age, knowing the anatomy of abnormal heart, status of corrective surgery, and the vascular access for heart chamber is essential. And the PLSBC is most common challenging obstacles for the CI implantation, especially for CRT. So knowing the anatomy of coronary vein is the key for the successful CRT procedure. SICD or EVICD is used for difficult vascular access, infection, or young patient who need not pacing. Leadless pacemaker is used for poor vascular access, but I think it is not good for young patient because there is an issue over the replacement and the extraction. And we have organized a CRT team in my hospital about 7 or 8 years ago. So we did cooperate for the CRT or other device with the heart failure specialist, image specialist, EP specialist, and nowadays we have more players. So pediatrician, cardiac surgeon also participate in the meeting, and we communicated very well about we have monthly regular conference for the CIED. I thank you.